A very warm welcome to all of you at the Center of Management of Healthcare Services at IIM Ahmedabad. We are fortunate to have Richard Thakor to present his awesome paper that talks about the link between the supply of credit to hospitals and the quality of their healthcare delivery. Richard is Assistant Professor of Finance at Carlson School of Management, University of Minnesota. The University of Minnesota is a place that makes Nobel laureates in economics. He's a research affiliate at MIT Laboratory for Financial Engineering. He earned his PhD in financial economics from MIT. He also has master's degrees from MIT and from London School of Economics. And obviously, Richard has published in the top-ranked journals. His research interests are in the area of empirical and healthcare finance, theoretical corporate finance, and exploring the role of financial frictions. Before handing over to Richard, you will be muted during the presentation, so you can type in your questions in the chat window, and we can take them periodically during the presentation. At the end of the presentation, say after about 45 minutes, we'll take more questions. We'll make the floor open. So now I'll be welcoming Richard, and I'll be handing it over to him. Richard, it's over to you now.
All right, well, thank you very much for the very kind introduction, Pranav. And it's really a pleasure to be here to be able to present this work. So this is joint work with Cyrus Agamala, who is a colleague of mine in the accounting department at Minnesota. Pinar Karachamandik, who is in the finance department, but she does a lot of work in healthcare economics. And then Xuelin Li, who is a former PhD student of ours who in this last job market, moved to University of South Carolina and started as an assistant professor there. So to jump into what we're doing here, the motivation is that hospitals play an essential role for both public health and the economy. In the US in particular, healthcare spending makes up roughly 18% of total GDP. And of course, as we're still experiencing, one of the key justifications for the partial shutdown of the global economy during the COVID pandemic were concerns regarding hospital overcapacity. So hospitals in general, I think, are important to study. And like other enterprises, like other businesses, hospitals need to obtain financing in order to operate. And credit markets are an important source of financing for them. So in particular, this provides a link between credit markets and hospitals and raises a number of important research questions. Do credit market shocks, for example, transmit over to hospitals? And if they do, in turn, do they affect real healthcare outcomes? And in general, I think understanding this question is important for understanding both the potential externalities of credit market shocks, given how important credit markets are for funding various sorts of institutions, but also how financial frictions may affect healthcare as well as health outcomes, which is something that hasn't been fully understood up to this point. So this is the basic motivation behind what we try and do here. So the goal of this paper, again, is to explore the relationship between credit markets and hospital outcomes. In order to do that, what we'll do is we'll utilize a staggered pattern of stress tests on US banks, and we'll use those stress tests as a negative shock to the supply of the bank's credit. And so the idea here is that hospitals are borrowing from those banks, the banks get shocked, and they transmit that negative shock to the hospitals. And so the hospitals suffer in some way financially. So we'll empirically compare hospitals with prior lending relationships to shocked lenders, to unaffected hospitals in a differences in differences specification. And then what we'll do is we'll compare a number of different hospital outcomes, so both in terms of financial performance and then a variety of measures of the quality of healthcare delivery. So that's the main goal of the paper. Just in case I don't get through quite all of the results, I just want to summarize the main findings here. So what we find as a summary is that in response to a negative credit shock, the affected hospitals experience an increase in loan spreads. So credit becomes more expensive, they borrow relatively less, and then they're more likely to switch to new borrowers. We find, interestingly, that their revenue and profitability increase, and we'll explain why this makes sense in this situation. In particular, this increase is driven by an increase in resource utilization, so they're getting more efficient financially, and they're decreasing their less profitable services. So financially, they seem to move in a good direction, but we find that healthcare quality declines across a number of different measures, both objective and subjective measures. And then finally, we find intuitively hospitals that are more directly exposed to these shocks, these stress tests, exhibit greater responses. And in just a few minutes, I'll get into much more detail regarding the details of our setting and what's going on here. But the main takeaway here that we want to emphasize is that in response to tighter credit supply, affected hospitals attempt to improve their revenues, but at the cost of worse care for patients. And this highlights an important spillover effect of credit market frictions on healthcare outcomes. All right, so what I'll do in terms of the structure of the talk is I'll first go through the institutional setting and kind of the details regarding the stress tests and what do we do. I'll then go over the data that we use in our setting, and then I'll go through the empirical strategy and finally the results. So what we do here is we utilize stress tests that were introduced in the US by the Dodd-Frank Act of 2010. We'll abbreviate that as DFAST in the upcoming slides. This affected large banks. So what happened is that after this was introduced into the law, large banks were required to undergo annual stress tests. And it actually staggered across a number of these different banks. So the first set of stress tests were that banks with assets that were above $50 billion had to undergo stress tests by September 30th of 2012. They then introduced the final rule and clarified this further, that banks with assets greater than $10 billion had to do it over the next 2 years. Now, even though they set these deadlines, they also staggered the implementation within each set of banks. So a number of banks could just basically go and lobby the SEC and the Fed, and basically request that their stress test be delayed because they didn't have the audit capacity and they didn't have all of the accounting capacity. So in general, these stress tests were staggered across the different banks, but they are clustered around these rule thresholds. Following the stress test, banks are inclined to improve capital adequacy ratios. So by improving the capital adequacy ratios after the stress test, what this ends up doing is lowering the credit provided or demanding higher interest rates from their borrowers. So there are a number of papers in the literature that have shown this. In particular, they've shown that these stress tests tend to be a negative credit supply shock. That once the banks are stress tested, they tended to increase loan spreads to their borrowers and reduce loan supply, particularly for the riskier borrowers. And I'll show you a little bit of evidence that hospitals are in this category. They tend to be riskier borrowers. So in general, what this means for our setting is that borrowers may face higher interest rates. And then if they face higher interest rates, they could either stay with that lender or they could move to another lender. But if they move to another lender, they don't have a relationship with that lender. And as the relationship banking literature has shown, relationships in banking tend to lower the cost of credit. So this is kind of the main logic behind the setting. This is graphically what we have in mind here. So you can think of Bank A over here, and it has a prior relationship with this hospital over here. And through the relationship, the hospital gets cheaper credit versus going to other banks based on their relationship with that bank. Now then, Bank A undergoes a stress test. And as has been shown, the stress test, because the bank feels inclined to improve its capital adequacy ratios, it has to basically reduce credit or increase the cost to riskier borrowers to get in better compliance, essentially. So it transmits this to the hospital. So the hospital either directly faces increased cost of credit or cost of borrowing. Alternatively, the hospital could try and turn to Bank B, but the disadvantage is that Bank B, the hospital doesn't have any existing relationship. And so either way, whether the hospital stays with Bank A or goes to Bank B, there's going to be an increase in the cost of credit for the hospital. So that's basically the conceptual setting that we're utilizing here. In terms of hospitals, why we think it fits for them is that, first of all, hospitals regularly utilize debt. Within our sample, the mean and basically the median debt to asset ratio for hospitals is around 50%. So I think the mean is 46% and the median is around 56%. So hospitals do take on a substantial amount of debt. Only about 7% of the hospital year observations in our sample will have no leverage whatsoever. So hospitals regularly utilize debt. Furthermore, there's evidence that hospitals are risky borrowers. There's a recent paper by Gao et al. That has shown that healthcare municipal bond yields tend to be higher and their credit ratings tend to be lower than comparable companies. So what this suggests is, as I mentioned before, when banks incur stress tests, they tend to transmit that to the riskier borrowers. This suggests that hospitals are in that set, and that banks may be inclined to reduce credit and raise rates when faced with stress tests towards the hospitals. And I'll also show you some direct evidence that that is the case in our setting. Now, in general, it's unclear how hospitals may react to the negative credit supply shock. As I argued, they'll face more expensive credit. Now, they may do things like implement cost-saving measures like reduce staff. They may try and increase per-patient revenue through admitting more patients, through pushing more overnight stays. And then in turn, it's unclear how this may affect patient health outcomes. So that's what we're going to focus on in this paper. All right, so in terms of hospital outcomes, so in terms of our data, we get data from a variety of different sources. So first of all, in terms of outcomes, we'll get yearly hospital outcome data from the Centers for Medicare and Medicaid Services, or CMS, and also a data set known as the Healthcare Provider Cost Reporting Information System, or HCRIS for short. This is pretty cool data. I'm actually very excited about it. It's detailed data for individual hospitals in the US and yearly data on things like hospital financials, bed utilization, employment, salary expenditures, and a host of other outcomes as well. Our data set goes from 2010 to 2016, and it will include just over 3,600 hospitals. Now, we'll supplement this with a few other data sets. One of this is hospital care quality outcomes. This is through CMS as well, through what's known as the Hospital Compare program. We'll use a few different outcomes here. One is unplanned 30-day readmission rates after discharge. This is informative about the efficacy of the initial treatment. The idea is that you go into a hospital to get treated for a condition like pneumonia or heart attack, which is two of the outcomes we'll look at, and then you're readmitted for the same condition within 30 days on an unplanned basis. So you haven't scheduled a visit, it's just unplanned. You show up at the hospital again. So that shows basically that probably on average, the initial treatment was not that good for the hospital. We'll also look at timely and effective care. This examines the proportion of patients receiving the most appropriate care shortly after admittance and also after discharge. So to give a couple of examples of this that we'll look at, one example would be if you have pneumonia and you go to the hospital, you receive an antibiotic for it. That would be considered the timely and effective care in the short time after you're admitted or you're discharged. Another example would be you get a heart attack, you go in, and then they give you a stent for the heart attack. That would be another example of what would be referred to as timely and effective care. And there have been another number shown measures. They tend to be used to evaluate hospitals, and they tend to also be good in terms of predicting patient outcomes afterwards. All right, in terms of hospital care quality, we'll also use the Hospital Consumer Assessment of Healthcare Providers and Systems data, HCAHPS. This is a patient satisfaction survey by CMS. It's about the experience at the hospital, so it's basically just a poll of people who stayed at the hospital. You can view this as a subjective measure of care quality, but it's nice because it has a number of different ratings for a variety of things. So it has overall ratings for just your overall experience, ratings for pain control, whether you felt the doctor and nurse communication was good, whether you felt the hospital was clean, was noisy, so on and so forth. The scales are different for each of these, so what we'll use as an outcome variable is the proportion of patients giving the highest rating. And then finally, in terms of loan data, to identify our shocks and our banks, we'll manually match our hospital data with the DealScan database, which provides syndicated loan data. We'll use term loan and revolver lending facilities starting in 2007 and onwards, and we'll focus on the lead bank. This will give us a sample of 537 hospitals that are exposed to these stress tests, and these are going to be our treated hospitals. Okay, so with that data in mind, I'll go and describe our empirical strategy. So what we'll use in this paper is a staggered differences in differences, or diff and diff regression. So this is the regression here. Y is our outcome variable. This is at the hospital year level. Our main treatment variable is the stress test ST exposed variable. This is an indicator variable that takes a value of 1. If at least one of a hospital's banks that they have a relationship with experience a stress test in either year T-1 or earlier, and then 0 otherwise. And so a hospital's relationship bank is defined as a bank that's lending to the hospital that has loans that have not matured with the hospital in year T. So the interpretation here, this beta coefficient, is that it will estimate the relative effect of the stress test exposure on hospital I compared to hospital year observations which have no relationship bank stress tests, so which are not affected directly by these stress tests based on the bank that they have a relationship with. Okay, so with that specification in mind, the variation in our treatment comes from 2 different things. The first is whether a hospital relies on loan financing from a bank that was subject to the Dodd-Frank requirements. And then the second is this staggered implementation of stress tests for different banks. Now, in terms of our identification strategy being valid, our main assumption here is that a stress test to an affected bank is exogenous to the performance of hospitals with relationships to that bank. Now, what we'll argue here is that reverse causality we think is unlikely for a few reasons. One is that the Dodd-Frank Act did not select banks based on, sorry, I have a typo here. They did not select banks based on anything else except their asset threshold. So they're not selecting banks based on the hospitals that they're lending to, but only based on their asset thresholds. The second is that the timing of the Dodd-Frank implementation was uncertain, both at the beginning and also when they kept on pushing the dates for various banks. And furthermore, the vast majority of hospitals in our sample have relationship loans prior to the implementation in 2012. So we don't see many banks trying to get new relationship loans after 2012. We'll also validate the parallel trend assumption, which I'll show you in a few minutes. Okay, so let me first jump in to the results. So the first thing that we try and do is we try and validate that the stress tests are indeed a shock to credit supply. So what we do here is we run a regression, which is measured for each loan between hospital I and bank J. So these are just at the loan facility level. And essentially, this is basically a cross-sectional regression. And what we're trying to look at here is that if a hospital's lender stress test, do the loans that the hospital have, what happens to the subsequent loans? And what we find here is that the hospital experiences an increase in loan spreads after a bank is hit with a stress test, they tend to borrow a lower amount going forward. So their new loans tend to be lower, or they draw down their loan facilities. They take shorter term loans, and then they're also significantly more likely to try and go to a new lender. So in total, this effect here is very consistent with the relationship banking literature and a relationship lending effect, that the hospitals are getting hit with more expensive credit, and therefore their options are just stick with the bank that they have a relationship with or try and go to a new lender. Either way, credit is going to be more expensive for them.
Richard, I had a question. If I
Yeah,
may.
Pranav.
Yeah. What was the loan purpose, if you could remind me, in these fixed effects? You have a loan purpose fixed effect. How do you find that?
Right. I am actually blanking on exactly what the loan purpose was. It's basically, it doesn't end up mattering in terms of our identification, but it's an identifier they have in deal scan.
Mm-hmm.
And I believe, yeah, I'm just blanking exactly on what that is.
Yeah, that's fine, because
I apologize.
in India we have, I don't know right now, but 10 years back there used to be a regulatory requirement that all the loans, their purpose has to be mentioned, and whether the money has been used for that purpose or not has
I
to be
see.
told to the bank with an auditor certificate. So
I see.
yeah, that's why I was intrigued. And there was another
I
question.
think it's
Yeah.
I think it's probably the same thing. I mean, what I do remember is that they had a few different categories for this. It was just a handful of categories.
Mm-hmm.
And when we looked at it, we didn't think it was particularly useful for us to condition on it or anything. But, I think some papers have tried to have used this as a fixed effect to control for it.
Uh-huh.
So, but I should remind myself exactly what that is.
Oh, no, that's okay. I mean, with these many fixed effects and their interactions, I mean, you're bound to forget something. And the data that you have used, the base data, is that paid or is it publicly available, or is it like this company location data, I'm forgetting, which is available only after you register for that audit and takes 18 months for you to get access to?
Oh, right. So the lending data is a paid database, but we have a subscription through the university. The hospital data actually is free. So it's actually publicly available data. You have to kind of know where to get it, where to go to get it, but it is publicly available data. There's another data set that's private data, that's American Medical Association data on detailed hospitals. It's kind of similar, but it has some different outcomes here. So we were thinking of using some of that data here, but we haven't incorporated it yet.
Great.
Okay, so with that in mind, in terms of interpreting the shock, we then try and examine how the stress tests affect hospital outcomes. And the first thing that we look at are the financials. And we find a very interesting pattern here, which is that once a hospital is exposed to a stress test through the bank that's getting the stress test, they actually seem to improve their financial condition across a few different measures. One is that their margin goes up. So the margin is defined as total income minus costs divided by total income. So their profit margin seems to go up. Their total patient revenue seems to go up. Now, we can scale by total assets or take logs. The effects are actually stronger with logs. But either way, we find a consistent effect that patient revenue seems to increase for both total patient revenue, inpatient revenue, and outpatient revenue. In terms of financial outcomes, they seem to draw down their cash reserve, and pretty consistent with the previous table, they take on less debt. So they have relatively less debt in their capital structure. So they're reducing debt, they're spending a little bit more cash, but they're increasing their profitability. Now, in terms of interpreting this more, what we then do to try and dig into this is we look at some service outcomes. So across a few different measures here. One is the occupation rate. This is the bed occupation rate for the hospital. That seems to go up after the stress test. The discharge rate also seems to go up as well. So in other words, they're utilizing their beds more. And as a result of that, the discharge rate is going up. They're kind of pushing the patient and discharging them even more than they did before the stress test. Salary for employees goes up, particularly this is physician salary. This is in line with more billing of services as well. And furthermore, the ICU, the intensive care unit bed rate utilization, goes down. So the interpretation of this is as follows. They seem to utilize their beds more. They're having a higher volume of patients. This is in line with more billing. They're utilizing their intensive care units less, and intensive care units, at least in the US, generally are unprofitable. So these are one of the units in the hospital that actually take a financial loss often. Now, overall, this picture is consistent with an increased financial efficiency for borrowers when they face tighter credit constraints. And this has actually been shown previously in the literature. There was a paper in the Journal of Financial Intermediation in 2011 that showed this sort of effect more generally, that when borrowers face tighter financial conditions, they try and save money however they can, and they try and increase their financial efficiency as a result. So on the surface, this, from a financial perspective, may seem optimal or seem efficient. But of course, hospitals are important as well because they provide an important public good, which is quality of care, quality of healthcare. So for many companies, we just really focus a lot on the financial condition and the profits. For hospitals, we also care about this other dimension as a social good. And in particular, as we showed, they're accommodating more patients. But what we also show in in additional tests is that they're not investing more. In fact, we actually see a reduction in investment. And they're also not hiring more staff. So they have the same staff, but they're accommodating more patients. So that implies that maybe something would happen with the quality of care. Now, in order to explore this, we'll examine hospital care quality across 4 different dimensions. The first is 30-day unplanned readmission rates. We'll look across all disease categories, but we have the most detailed data for heart attack, which we'll call AMI for acute myocardial infarction, heart failure, which we'll abbreviate HF, and then pneumonia, which we'll abbreviate PN. We'll also examine timely and effective care. As I mentioned, this is whether patients have received the appropriate treatments around arrival and then discharge for these conditions. We'll look at some mortality numbers and rates to see if this actually translates into more, survival outcomes. And then finally, a subjective measure of patient satisfaction ratings. All right, so the first thing that we'll look at is unplanned readmission. So we have the 3 main disease groups that I mentioned, so heart attack, heart failure, and pneumonia. And then we have all diseases as well, which includes those 3 as well as all others. We see for all of these that the rate of unplanned readmission goes up. And actually, in terms of magnitude, this is quite substantial. So to give some context, in the US, the biggest effort to try and reduce unplanned readmissions was the Affordable Care Act, which was, I guess, about 10 years ago or so. That magnitude is basically erased by these numbers right here. So these numbers are basically an increase in unplanned readmissions that's equal to the largest decrease that's been managed by policy initiatives. These last 4 columns here are trying to look at this from a different perspective. So what we look at is, instead of the rates, we create a dummy variable that's equal to 0, but it's a 0, 1 dummy variable. It takes a value of 1 if the hospital moves to the worst category in terms of readmission rates across all comparable hospitals in the US. So we see for these last 3, and this has the right sign, but it's not quite significant. The hospital is significantly more likely to move to the worst category in terms of unplanned readmissions. So it seems very consistently across the board that unplanned readmissions, which again is a measure of the efficacy of the initial treatment, seem to go up once a hospital experiences a stress test. Now, as another measure of timely and effective care, we look at basically, this is actually drilling down into those numbers, whether the patient is receiving the most effective treatment for the given condition here. So this is kind of giving a more detailed look at this. So for example, the first column here is the patient getting aspirin in terms of pain when they experience a heart attack? Column 2 is PCI, percutaneous coronary intervention. And this is basically if you have a heart attack, do they put in a stent, which is the flexible tube that go in your arteries to increase the blood flow once you have the heart attack. Statins, do they prescribe a statin after a heart attack? That helps lower cholesterol and helps improve outcomes. Do they have a let's see, this is left ventricular, I think, systemic evaluation. But this is if you have heart failure, basically do you do the imaging and the proper treatment to evaluate that. ACE and ARB inhibitors are also helpful in terms of heart failure. And then finally, for pneumonia, do you get prescribed an antibiotic after you come in for pneumonia? We see really across almost all of these measures, we have a significant decrease in the effective care for those measures. So that's very consistent with the previous table, that the hospitals seem to not be doing as good of a job at doing the right treatment once they're exposed to the stress test through the back. And this is also just intuitively consistent with the fact that the hospitals are more crowded, and basically the doctors may be too distracted as well. And that's filtering into the lower care quality. Now, we also look at mortality. We look specifically at pneumonia mortality for a couple of different reasons. One is that the mortality numbers overall, the data, we have to construct the data. And in particular for the other two disease categories, AMI, so heart attack and heart failure, the data is really not filled in very well. And there's also an issue regarding timing, which is why the data is not filled in. That, for example, you go in, you get treated for, say, a heart attack, but then they don't do a good job, and then you unfortunately die at home. That doesn't necessarily filter into the mortality rate. So there's some issues regarding the timing for heart failure and heart attack. Pneumonia also in particular has an interpretation that a big source of pneumonia can be hospital-acquired pneumonia. So pneumonia you're actually getting and infected by in the hospital, which previous studies have shown that hospital overcrowding can be a key determinant of whether you get hospital-acquired pneumonia. So that kind of jives with the previous results. Now, what we find here is that the raw numbers in terms of mortality from pneumonia, the mortality rate in terms of patients admitted, and if you're in the worst category in terms of mortality for pneumonia, all three of these increase following a hospital that's been exposed to a stress test through its bank. So this shows that actually this really has important implications, because not only is the care quality going down for these hospitals, it's actually filtering into the mortality and the survival of the patients themselves. Now, the final measure that we look at is the patient's perspective, so basically a subjective measure of care quality. We have a variety of different measures here. It's very consistent effect for all of these measures. We have overall ratings, pain control, whether the patient felt that their pain was controlled, whether they would recommend the hospital, how clean they felt the hospital was, how good their communication with the doctor was, how good the nurse communication was, whether they felt they were provided appropriate information, and whether they thought that the hospital was quiet enough. And across all of these measures, it goes down. So the subjective measures go down, indicating that the patients feel that they're also having a worse experience at the hospital. So I'll just briefly show parallel trends. So essentially, we don't find any pre-trends before the banks get hit with the stress tests. Then we have find an effect after they're hit. So you can see for leverage, it drops after the stress test. Similarly for cash, payments to doctors increase, bed occupation increases after the stress test, discharge rates increase significantly, and then ICU utilization rates decrease as well. So what we're doing to construct this is we're basically just interacting a time dummy with our treatment variable and looking at the treatment interacted with the time dummies for the years before the treatment, so the stress test, and the years after it. Very similar pattern for readmission rates for both heart attack, heart failure, and pneumonia. These are the pneumonia mortality numbers. So again, we don't see any significant or discernible trend before the stress test, but then we see a movement after the stress test. And then finally, I'll briefly show this. This is the patient care ratings, the subjective ratings, and very similar pattern here. So I'll just highlight the overall. We don't see very much of a trend at all before the stress test, and then the overall rating drops in the years after the stress test. All right, so the next thing we do is we look at heterogeneity. And the idea here is that intuitively, if this credit supply channel is responsible for our results, we should see stronger effects for more affected hospitals. So what we do to try and look at the more affected hospitals is we look at the ones that are connected to banks that are more affected by stress tests. So we follow the literature, in particular a recent JFE paper by Philip Strahan and co-authors. We use the minimum stress test distance from failing stress tests. So basically, we're looking at how far a bank is from failing the threshold for a stress test based on the criteria that the Fed has. So what we do is we just take our treatment variable, the stress test exposed, and we split the treatment variable into two different variables here. So weak exposed and then strong exposed. So weak exposed means that they're closer before the stress test to failing the threshold for the stress test. And consistent with this, we generally find stronger effects for the banks that are closer to failing the stress test. So I just take a sample, it holds for wider variety of our measures, but just a sample of the different measures here, that the measures seem to be concentrated on the weaker, the hospitals exposed to weaker banks. Now, another source of heterogeneity, we also look at hospitals that are more dependent on debt financing, and these should be the hospitals that are more affected. So what we do is we examine hospitals that have unmatured loans, scaled by total assets, and then we examine if those loans are above or below median. So put differently, are they more reliant on loans relative to other hospitals? So again, we split our treatment variable here. This first one is the ones that are more reliant on loans, and then the second one is less reliant on loans. We split that on the median. And again, we find the strongest effects for the hospitals that are more reliant on loans, and they're affected by the stress test. And then we also show that hospitals with more bank loans from stress-tested lenders are more affected. So before, we were just conditioning on, do you have any lender that basically is exposed to a stress test? Well, hospitals, sometimes they'll borrow from one bank, other times they may borrow from another, from a number of banks. So intuitively, the ones that have just more of their loan portfolio concentrated in banks that are exposed to the stress test should be the most affected. And that's again what we find. So we find that the effects are concentrated on the ones that have bank loans, more bank loans from stress-tested lenders versus the ones that have less bank loans from stress-tested lenders. Now, we do a number of robustness tests. I think in the interest of time, I'll just describe these rather than going into them. There are other stress tests. The Dodd-Frank Act was the main and the major stress test. and that was the one codified into law and creates a stricter examination. There were other stress tests that affected a few banks before the Dodd-Frank Act, such as the Supervisory Capital Assessment Program and Comprehensive Capital Analysis and Review Program. We examined these in the paper, and we find little of evidence of the effect with other stress tests. So the effects seem to be really concentrated with the Dodd-Frank Act. And we think basically because it's a wider set of banks, so it gives us more power, and also it carries a stricter examination. But our results are also robust. If we just include as any stress test, including these, our results remain almost the exact same. Now, regional differences, there are concerns that geographic clustering may induce some of our results. So I'll actually just show this real quickly. This is a graph of the US, and basically these are hospital referral regions. So basically like a region where if you lived in this region, you would tend to be referred to that particular hospital within that same region. And this shows the number of hospitals exposed to stress tests. And so the concern here is that there's some sort of geographical clustering of hospitals, and therefore a certain bank may be the dominant bank in that industry. And so you have some sort of concerns regarding reverse causality, like the economic conditions in the particular area affected both the hospital and the bank. And so we might find a result that's related to that, but not the stress test. So what we find here is we actually, if we graph this, we don't actually see that much geographical clustering. Now there are a few, if you notice, areas that have a number of different hospitals that are exposed to stress tests, like these two areas here. But for the remainder of the US, it's really kind of pretty dispersed, we think. So it doesn't seem to be that much clustering. Now, with that in mind, though, we try and explicitly control for this. So we map each hospital's location to a referral region. We throw in, as a robustness test, region by year fixed effects, so time varying geographical fixed effects, and we still find the same results, which implies that it's probably not driven by this sort of geographical cluster. And then finally, some hospitals in the US are attached to hospital systems. So it's basically just an overarching organization that kind of runs different. There are some concerns that hospital systems, those types of hospitals are different from other types of hospitals that are standalone. So our results are similar when we restrict the sample to just hospital systems as well. And we try and exclude various slices of the data. And we can also put in some fixed effects and we'll get basically the same thing. Okay, in terms of our contribution here, we contribute to a few different literatures. One is the impact of credit constraints on investment. So we differ because we specifically look at the link of credit constraints on healthcare, providing evidence of important spillovers from credit markets. We contribute to the relationship banking literature, but we show specifically that a negative shock to relationship banking can also reduce the quality of the service provision of a public or social good, which we think is a new contribution to literature. And then finally, there's a pretty small literature that's at the intersection of healthcare and finance. And I think it's starting to grow. So in particular, there are a couple of papers by Manuel Adelino and co-authors, and then Gao et al. That's trying to look at the link between hospitals and, say, investments during the financial crisis, looking at hospitals as nonprofits and looking at their investment behavior. We contribute to this literature because we're documenting the link between hospitals and credit markets, in particular banks, and we believe that we're the first to do that, in turn showing how credit markets can influence care quality. All right, so to conclude, this paper explores the effect of credit supply shocks on hospitals. We utilize variation in stress tests conducted on banks and examine outcomes for hospitals that these banks lend to. And we find that in response to a negative credit shock, increase their revenues. And so we view our results as providing novel evidence of the dependence of hospitals on credit markets. And this shows an important connection between credit markets and public health. So thank you very much. And thank you especially for joining, since I know it's quite late over there. It's early in the morning over here. But I appreciate the opportunity to present this work, and I look forward to any questions.
Mary, let us know if there are any questions. I don't see any in the chat. Looks like everybody is convinced of the strategy, identification.
Or everyone is very sleepy because it's late over there.
Yeah, saying dinner time. Yeah, they're munching something in the silent mode.
Right.
Let those questions come. Before that, I had one question, Richard. Just I was thinking, there used to be a literature on these instrument variables. So I took a course in labor economics, and because that only talked about role of education in increasing salary, like there was zillion papers on that. So I was wondering, the good and bad of, rather than using a staggered difference in difference, but something like an instrument variable saying that stress tests affect hospital outcomes only through change in the credit supply. I'm wondering, the good and bad. Yeah.
Yeah, that's a very good point. That is implicitly what we're arguing here. So, this sort of staggered diff and diff is basically, basically a reduced form for an instrumented differences and differences there. And that's actually the key to our identification strategy, that we're assuming that the credit supply is affecting the hospitals. The stress test is affecting the hospitals only through the effect on the credit supply. Now I think we could try and actually run the regression like that. So we sort of have a first stage here. So we could try and use this as the first stage. So stress test predicts spread, for example, so as a measure of credit costs, and then instrumented spread goes and affects the different outcomes that we're looking at. That would be kind of the fully instrumented version of our diff and diff strategy here. But yeah, what we do try and argue in the paper is that the effect is operating primarily or exclusively through the credit supply channel and not through other things. That test that I showed you regarding the geographical differences, that kind of is getting at one story that you could think of where it's operating through, say, local economic conditions or something like that.
Yeah, sure. Yeah. There's a question about email ID that is available on the website. So thanks a lot, Richard, for taking out time and for giving such a wonderful talk. I learned a lot from your presentation and from your paper.
Well, thank you very much. Again, I really appreciate the opportunity to be able to present this. This is still early work, so we actually haven't distributed widely any drafts. We're hoping to get a draft done soon. So it's always great to be able to present this sort of work. And again, I appreciate the invitation and also everyone coming so late at night over there.
Thank you. Mary, so shall we close the presentation? There are no questions.
Sure, sir. We can.
Thank you, Richard. Have a nice day.
All right. Thank you very much. You too.
Thank you, professors. Thank you so much.
Thank you all.